All right, then I'll start. I'm so sorry for the difficulties we've had this morning. I've got a feeling it was my fault, so I can only apologise profusely. I'm going to go straight into it. All these slides and everything will be shared afterwards. So, and any questions, please come to me. I'm really sorry about the mix-up today. So I'm Kim Rezel. I'm the Head of Patient and Carer Engagement at HQIP, the Healthcare Quality Improvement Partnership. I'm presenting today with Meg Hill, who is one of our Service User Network members, and also Sandie Woods is going to join me as a Sun member in announcing our judging announcing our Audit Heroes this year, because Sandie was part of the judging panel. Okay, so what we're going to talk about, I'm not sure if there's anyone here who don't know who HQIP are, but I'm going to do a quick couple of introductory slides, and then also a brief introduction as well about our Service User Network. But the key focus for our presentation is that we're going to talk about a focus group we held a few weeks ago, in which we asked our Sun members about patient advocacy in healthcare and also about their views on shared decision making. So Meg and I will be sharing highlights from that discussion. So just briefly, HQIP is an independent not-for-profit organisation, and we work in partnership with patients and healthcare professionals to influence and improve healthcare practice at all levels. Our core business, as many of you know, is to commission the National Clinical Audit and Patient Outcomes Programme, the NQICAN. And as part of this, we work really hard to ensure that patients and carers are at the heart of this work. And how do we do this? Well, in many ways, but a key component is our Service User Network. And we established our Service User Network in the very early years of HQIP. And initially, they advised us in our resource development, QI processes, and then it really grew into our commissioning process as well. And engagement within this process has evolved and improved over the years to embed patient engagement into our commissioning to deliver better long-term value and outcomes. Quick diagram with our different work streams. I won't go into detail, but an important note is that we try and embed our patient and public involvement, PPI, into all of these work streams. And I work across most of these areas, and we involve our Sun members as much as possible. The only exception is the purple strip there. That's the National Joint Registry team. And whilst we share learning and ideas across the teams, the NJR actually have their own team working on PPI and their very own patient network as well. Right, so who and what is our Sun? Last year, I talked about a change in our engagement approach with Sun members. So I'm not going to repeat that here, but just to say, we now have 130 members actually from all over the UK. And with several members last year, a good piece of work from last year is that we co-produced a working in partnership with patient advocates involvement policy. That's available on our website, and so you can all access it. And this sets out expectations and processes, as well as the involvement fees when engaging with HQIP. So for anyone interested in joining our Sun as people with lived experience of using healthcare, you can sign up online to receive newsletters or targeted emails for opportunities to be involved. So a final slide before moving on to the main bit of our presentation. This shows the demographic makeup of our Sun members currently, well, about a month ago, to be honest. But I'm really proud that we have really increased the diversity of the network in terms of age and ethnicity, and we try to make sure that each activity we do has diverse experiences. So why do we work hard at HQIP to facilitate and engage with patients and carers? Well, I think most of you know why. This list is not exhaustive. There are a million benefits to PPI, patient and public involvement. And that's not just in our own treatment and care, but also in QI, commissioning, service design. Lord Darcy highlighted in the recent review of the NHS that the patient voice is not loud enough, that they feel disempowered with their concerns overlooked in decision-making processes. He also noted that the declining satisfaction from patients and a rise in complaints led to compensation payouts totaling nearly £3 billion. So if that's not a reason to do it better, I'm not sure what is. So he also said that activated, engaged patients enjoy better health and safer, more effective healthcare. So we asked our Sun members what they thought of this, and we held a focus group last month, and we discussed these two themes, so patient advocacy in healthcare and also shared decision making. So with the participants' permission, we filmed the session, and the full discussion can be found on YouTube from today. So watch out for clips shared on social media over the coming weeks. So let's see, we've had such bad luck today with our technicals, so I'm going to see if I can share a video. But first, just to say, these are the questions that we covered. So we asked about why do they want to be involved, the difference between local and national involvement. We asked about payment for involvement, and then what they also most asked about when they're doing patient advocacy. Okay, so let's see if we can share this video. Bear with me. Here we go.
I'm always trying to consider other people's experiences. So if there is something that I can bring from all that actually improves services and actually really makes a tangible difference, then that's important. So I guess it's just trying to make things better for as many people as possible, really.
Yeah, well, basically, I wanted to get involved in patient-public involvement because it's the public's right to. The public have a human right to talk about the care and treatment. And I wanted to try and break down some of the barriers and cultures to involvement that I'd encountered as a lived experience. Not only that, but for educational purposes as well, feedback some of the positive care that I'd had whilst going through 2 types of cancer. I think that's very important, not to dwell on the negative, but to challenge some of the practices and to look for gaps in services as well. I think that's really important.
Firstly, there was a care of both my parents, and they didn't speak English, so it was making sure that they were not miscommunicated. I actually got to all their appointments to make sure that they get the right services and not misinterpreted by interpreters. So that was earlier kind of carer role. And then more over the last 5-6 years, I was trailing through lots of patient public involvement kind of groups on different organizations and institutions. And I was appalled by, in the Midlands, certainly where I am in East Midlands, the patient public involvement Senate, when I looked at it, was non-diverse. Got involved on that basis.
Hopefully you all heard that. It's hard to know. So we have the full video where you can view using this QR code, and you can hear some great insight from our Sun members. Hear their views on the other questions we asked. But for now, I'm going to pass over to Meg. So Meg, hopefully you can speak.
I can, yes, thank you. Kim just repeated some words from Darcy a moment ago, that patient voice isn't loud enough. I'd like to turn that around and say actually healthcare systems aren't listening well enough, because as patients can be quite loud when we need to be. It's important that clinicians and policymakers consider more than just their worldview when it comes to healthcare systems and creation. We've all got different backgrounds and experiences that influence our health, and they need to be considered when creating policies and procedures. No matter how good you think that you are at seeing things from other people's perspectives, unless you've lived in their shoes, then you just can't fully understand. It's important as well not to assume that people sit in a particular cohort of people. I'm an expert by experience, just like the rest of the table are experts in their own fields, and my time and input is worth no less than theirs. Patient advocates should be involved from start to end, from the conception of an idea through to the implementation and evaluation. Healthcare organisations are getting better at realising that patient involvement is necessary, but it is still too often a bolt-on and a tick box exercise rather than a fundamental part of a project. Thank you, Kim.
Thank you, Meg. That's brilliant. We'll hear back from Meg in a bit. So I'm going to move on to the second theme we discussed, which was shared decision making, and this is a key component of person-centred care. So shared decision making is a specific process within person-centred care, where clinicians and patients work together to make decisions about our care. So I saw this presentation last week from Professor Alf Collins, a trustee at PICA Europe, and he shared this slide about person-centred care is just good care, and we have it's ethical, it's a professional standard, and we have clinical legal obligation. So what did some members think? These are the questions that we went through in the focus group about whether they felt they were choice was introduced, if they were supported to make decisions, did they feel there were joint decisions with the healthcare professionals, and what do you think healthcare professionals could do to improve? So we're going to press play again. Bear with me. Okay.
I think they do their best. You know, they do their best. When you talk, I'm a heart failure patient. I had open heart surgery. I've only had my recent appointment with a cardiologist, and he did his best trying to explain to me things. But sometimes the language can be quite technical, or it can be quite medical. Like, you know, 50.8 VLLVEE, and they say your heart is functioning at 50.0. I was like, I don't know, I have a clue what this goes on, what does it mean? And stuff like that. And then they talked about, you know, all these different terms. So that can be quite, and I think if you're not confident, you usually want to just nod your head like you understand everything, everything makes sense to you. But if you're confident, you might say, could you please explain that to me in a most simplest way? But time is always against you. So I had to come home and really Google things and YouTube things and try to make sense of what it meant, because I didn't have the confidence to say, can you explain that to me in a simplest fashion? So I want to end up on the fact that clinicians do try their best, but because they're so used to speaking that clinical language, they forget that you're not in that world. And for you, it's just French. You have no idea what they're talking about.
I felt like I wasn't listened to at all, that I had options I wanted to explore, but the doctor essentially was like, no. And I had several different options I wanted to explore, and essentially I was told, if you're not going to go on this medication, then I'm going to discharge you from our care. And I was like, well, I don't want to, because it's making me sick. So for me, I feel like it wasn't a joint decision. It was, you either take this or I'm no longer helping you. And unfortunately, I couldn't take that medication because it was making me very ill. I have been in situations, for example, with my mental health care, where I felt like the decisions were very joint. My therapist was very clear with me what my options were, that we'd go with whatever I needed. And I remember one time it was a conversation that she started saying that I think what we're doing is working well. However, I think you might benefit from this other service, and sat down and explained it to me and said, what would you like to do? Would you continue with me? You've got another couple of sessions, or would you like to go to this one? And I happily went to the one because we actually had that time to talk over it, and for me to understand where she was coming from and how that fit in with my options.
I think professionals need to understand the importance of person-centred care, and that the patient is much more likely to engage with their treatment plan if they have been involved in creating it. I think they should engage more with those who have lived experience so that they can hear how beneficial shared decision-making is. Allowing the person to be involved in their care promotes their sense of self-respect and dignity, and allows them to still have some autonomy over their life. Services when I was a child, I didn't feel that I had any control over any of my care. I don't feel like I was informed. I don't feel like I was given any choice over anything. I think as an adult slightly more, but I still feel that there are some professionals that just always feel that they know better. And even if you kind of feel differently, they'll kind of try and persuade you to think their way. They're going kind of like, I have felt into their decisions as if they're the right ones, and they'll just try and convince you that they're the right ones, even if you know that it doesn't kind of feel right for you, and it can feel quite intimidating. So I personally don't feel like I have been that listened to regarding my care, no.
Some really mixed responses there, but hopefully you'll be able to see the full video and you can see some really good examples as well. But just then, that's Naomi at the end saying she has not felt listened to, especially when she was younger. And I'll just take this opportunity to say a big thank you to all our SUM members who participated in the focus group. So this is actually a care measure that I found, and I wondered how widely this is used in your organisations as something that is a really good measure to understanding what kind of person-centered care is going on. And I also heard, this is a great slide, I heard from Professor Alf Collins about the value of empathy. And I think this is a great example of empathy here, a quote from Archie Cochrane. I'll give you a second to read it. And I was thinking about perhaps medical students should be learning more about empathy in their training. Evidence apparently suggests that doctors are more likely to burn out without empathy. We should be trying to understand what matters to patients and learning about individual values and preferences. So the more we can support healthcare professionals to show more empathy with clinicians trained, and also to support patients to be more informed and prepared, perhaps our time-limited appointments would be sufficient. Especially with long-term conditions, conversations can unfold over time. And if clinicians listen to patients, maybe we can achieve better outcomes. So this is a final slide about how to reliably implement person-centered care to the highest possible standard. It's about culture change, continuous improvement, empathy, and co-production. These are a few more quotes from the Sun Focus group, but I think for now we'll hand over to Meg.
Thank you. For me, shared decision making is somewhat of a misnomer, because legally and ethically the person making the decision about a course of action can only be the patient. This means that all available options need to be presented alongside the benefits and risks of such. The crux of shared decision making is personalised conversations, where you need to understand the person in front of you. This comes down to time, curiosity, and the removal of the hierarchical and sometimes ego-driven nature of healthcare to allow honest, nuanced relationships and conversations to develop. Unfortunately, we do know that the system is not built to support relationship-based care. There are many healthcare professionals who are superb at these conversations, and there are others who are not so good. This might not be the individual's fault, though. Having these nuanced evidence-based conversations is a skill, and it often needs to be taught and practiced. Many staff are under-resourced and overstretched, and relationships like these take time. There's often a lack of curiosity about evidence. The policy says this, so that's what we recommend, whereas the evidence base might be out of date or maybe not as robust as we think, or maybe flawed in the first place. And crucially, you might have a patient in front of you who opts not to follow your recommendation, and you still need to support them. I mentioned systems-based failure in respect of there being time to have these conversations, but we also need to consider the impact of how the system is built too. For patients to make good decisions about their care and to understand their care and how they can access it in the most appropriate way, there's a necessity for staff to work in a multidisciplinary way and to involve service users when creating these pathways and protocols. To give an example, we have just come out of, we got the all clear yesterday, a quite scary health situation for my daughter. The clinical staff have been absolutely excellent at giving information and talking through diagnostic options, even changing the diagnostic plan off my input. However, I have had to resort to asking in a local Facebook group to understand the test procedures properly so I can support a neurodivergent child through them. If service users had been able to co-create this service, this information would have been shared at the point of the appointment being made. Crucially, shared decision making isn't important just for the patient. These conversations benefit staff too, improving the patient-carer relationship, increasing job satisfaction, and ultimately positively impacting engagement, retention, patient outcomes, and work culture. Thank you.
You there, Meg? Meg?
Thank you for your time listening to today's presentation. Before we take questions, we'd like to ask you to reflect on how you'll take the topic back to your workplace and increase patient participation in whatever your role is.
Thanks, Kim and Meg. Is it at this point we're moving to questions, or are you just giving people a few minutes to reflect?
No, we go for questions if we've got time, or I'm not sure.
yeah, I think we're because of the tech issues, Kim, we'll hear from yourself and the winner, I think, and because they're the important things that people have joined for, aren't they?
Yeah,
So
I think.
have we got any questions? Would people like to raise their hands? We have got the chat function as well, so I'll scroll up and down the chat, and then if anybody's got any questions, could you raise your hands? Not seeing anybody raise their hands at the moment, Kim, so what we could do is we could move the slides on.
Brilliant. I think that's what we'll do. So hopefully,
Fantastic.
Sandie, you're there.
Yes, I'm here.
Brilliant. Over to you.
Thank you. Well, I'm a member of the Service User Network, and it was a real pleasure to be on the judging panel reviewing the submissions focused on patient and public involvement, and to be here today for the award ceremony. So thank you. I'd like to just say a few words about the criteria and the process we followed, and also to announce the runner-up, and then I'll hand over to Kim for the finals. And so we read and we judged each application individually against a set of criteria before the team came together to give feedback and to share the scoring and to reach a final decision. So what did we look for? Well, we looked for a clear rationale for the audit or quality improvement. We thought about what existed before and how the change addressed the quality of care provided. We questioned whether it was actually quality improvement and innovation, or what would be expected of any service. We reviewed the project design and how the topics had been aligned with patient priorities. We looked at how the need had been identified and how the patients, public and carers had shaped the service improvement from the outset. We look for co-production at every stage, the planning, the implementation, the evaluation and the sustainability of the change. We reviewed the methods used and saw some very innovative ways to engage. And we considered whether attention was given to listening and to communicating in different formats that were accessible and inclusive at every stage in the process. It was also good to see transparency in sharing the challenges along the way and actions to address any difficulties and plans for the future. Considering all these points and all the discussion, we came to our final decisions and we were unanimous in selecting the 2 winners and the runner-up. I'm going to announce the runner-up and then I'm going to hand over to Kim to announce the winners. So with the runner-up recognised the importance of customer service and initial contacts in front-facing roles, improving access and reducing barriers to care. The application demonstrated partnership working at every stage, different modes of communication, and innovative methods to get real-world feedback, which included a mystery shopper. Train the trainers and online modules also demonstrated attention to the quality improvements and sustainability. And the runner-up is Welcome Standards QI programme at the University Hospital Sussex, created in partnership with Health Watch, Nicole Shavardra. Well done. And I'm going to hand over now to Kim to announce the winners.
Thank you so much, Sandie. Okay, we've had joint winners for the Patient and Public Involvement Hero. So our first winner is Lisa Wilson, the Triangle of Care from Midlands Partnership NHS Foundation Trust. And unfortunately, they couldn't join us today to present, but HQIP will be making case studies of all our winning submissions from the week. The judges really liked this submission because there was the involvement of carers and service users in a therapeutic alliance aimed at promoting safety and recovery and to sustain well-being by including and supporting carers. This was a collaboration between the involvement and clinical audit teams, looking at patient feedback and producing an audit tool that included local guidelines and supported data collection to facilitate benchmarking across teams. They formed a scrutiny panel, which included carers and volunteers to manage recommendations and actions from the project. So we like the outcomes, we like the involvement, and we like the outcomes with the addition of carer information and welcome pack, and also the ongoing nature of the project with regular assessments and re-audits. So well done to Lisa Wilson and the team there at Midlands. And our second winner is the McPin Foundation for their work with the National Clinical Audit of Psychosis. I won't say too much about this project as Vanessa and Vinu are here to present, but just to say the judges really liked the engagement with the service user and carer reference group and how they were part of the decision making on all key elements of the audit. So let's hear from them. So I'm going to end and stop sharing now. And hopefully Vanessa and Vinu, they've got their slides.
Thanks, Kim. Thanks, everybody. And thank you so much for giving us this award. I'm the co-founder and research director at the McPin Foundation, and we're a small mental health research charity which specialises in public and patient involvement. And so as such, I kind of know how hard it is to do this, and we really value the projects where we can learn together and innovate. And I nominated this award. I nominated the Service User and Care Reference Group for this award because it's a recognition of the journey that we've been on together over 3 years. It hasn't always been easy. We joined an established programme of work to try and innovate, and joining an audit programme and trying to kind of do co-production with an audit programme which has got very, very strict parameters and there's lots and lots of moving parts can be quite challenging. So we tried to write a frank and honest submission of our journey together, and so it's great to have the recognition that even though there's been challenges, this project has been it's been amazing, and we're here today to represent the whole of the group. It really is teamwork. They say teamwork is dream work, and I think that when you can take on board honest feedback and everybody can step in each other's shoes and try and think about things from different people's perspectives and try and make changes together, you can achieve things. And this is what Vinu is going to talk about, the way in which we've worked together to produce an audit report which has had the involvement of which has been led by our Service User and Care Reference Group. Vinu.
Yeah, thank you, Vanessa. Just wanted to echo that we're so grateful to receive the award on behalf of the PPI group for the National Clinical Audit of Psychosis in terms of developing the State of the Nation report. So it's really been a challenge in terms of integrating and navigating and negotiating multiple perspectives. So if we move on to the next slide. So I just wanted to give some background on the history of NCAP and the development of the Service User and Carer Reference Group and the wider NCAP team that we belong to. So I've seen many staff come and go in my 6.5 years as Service User Advisor to the audit. So I just wanted to give a nod to the previous director, Professor Mike Crawford, and now we're expertly led by Professor Dasha Nichols, as well as our former clinical advisors, Professor Joe Smith and Dr. Paul French, and now we're expertly led by Professor Belinda Lennox and Moggy, and my role as Service User Advisor will also be coming to an end soon. And also just to completely note the important development of the Service User and Carer Reference Group that have been integral for the past couple of years in terms of informing the audit. So a nod to Stephen, Jason, Iona, Ross, Janet and Hayley, as well as McPin Foundation and Vanessa for expertly chairing the group and integrating our voices into the audit effectively. I know it's been a challenge coming into an audit that's already kind of had parameters, and it's been a negotiation. And we also have our quality improvement leads, Maureen and Sive, that contribute to the audit, as well as many project officers that have come and gone. And I've seen about 4 different project managers in my time. So it's been a real collaborative experience and a negotiation of multiple perspectives. So if we move on to the next slide. So in terms of the structure of NCAP, the Service User and Carer Reference Group is at an equal footing with the steering group as well as the implementation group where decisions get made. And I know that Vanessa chairs the group in a really collaborative way and people feel heard and listened to. But my role as Service User Advisor is to bridge the gap between the Service User Reference Group, the steering group, as well as the implementation group to ensure that lived experience is represented and integrated into all the decisions that are made throughout the audit. So if we move to the next slide. So I wanted to give some background around early intervention in psychosis services are, so you get an idea of where the NCAP audit fits in. So essentially, early intervention services provide holistic support to patients with psychosis. It spans psychological support, psychiatric support, social support, and family and carer interventions. And what the NCAP audit does is audit the audit service provision in relation to co-produced standards of care to ensure that we're holding them to account. And those standards of care are things like timely access to services, CBTP, family intervention, prescribing of clozapine, employment support and education programs, physical health screening and intervening, carer-focused education programs, and outcome measures. And what teams can do is assess their performance over time by comparing on an annual basis, so they can see how well they've performed over time, as well as compare and make comparisons across other services, which can help them drive up the quality of the care that they provide, as well as the data collection that they capture. So if we go on to the next slide. So yeah, in terms of my role as service user advisor, I come from a perspective of having psychosis and having used early intervention in psychosis services. I represent that voice on implementation group meetings where I ensure that lived experience is embedded in every decision that we make as a team. I also represent this voice at service user and carer. I kind of communicate the perspectives of the service user and carer reference group in steering group meetings as well as in the implementation group meetings. I often have a seat at the table where I can make an influence with people like NHS England, our funders, our commissioners, HQIP, as well as clinicians that effectively inform the audit. And in terms of the service user and reference group that is expertly chaired by McPin Foundation, we meet on a regular basis to ensure that we are drawing on those experiences effectively, and we do develop good relationships and connections. We have 3 service user representatives and 3 carer representatives, and this adds voice and weight to my own experiences and the decisions that are made, and it gives me an element of peer support as well. So if we move on to the next slide. So there were some challenges in terms of creating this national clinical audit of psychosis State of the Nation report. We had specifications of only having a 10-page report and condensing a couple of years worth of data into that report. We also needed to navigate multiple different stakeholders and perspectives from clinical advisors, my own perspectives as from a lived experience perspective, the service user and carer reference group, the project team, the steering group, as well as our commissioners. And we needed to also identify important data to report on, but also identify key recommendations. And there were significant challenges around this data. There were delays in terms of accessing this data, so we had a limited time frame from which to make decisions. So we had to really come together and kind of navigate those different perspectives. So essentially, we were presented with data from across a number of years. We needed to obviously navigate those different perspectives, and we asked for the data to be cut in different ways so we could better understand the data and make meaningful decisions around what we report on. So we decided in terms of what was equitable access to service provision and what was inequitable access to service provision that we thought would make a meaningful report. And we also brought the data to life by identifying why those particular areas that we reported on mattered to service users and carers. So if we go to the next slide. So we identified it was essential to report on timely access and comparing standards over time across each service provider. So that can be seen at the very beginning of the report. We also identified the importance of reporting on CBTP as well as family intervention, and the importance of that is highlighted by our patient and public involvement members. We also identified the importance of focusing on children and young people, as well as at-risk mental state, and as well as that health inequalities and regional differences. So you can see how we've brought the data to life by sharing our own perspectives around why this data is important. So if we move to the next slide. So we did ask our service user and carer reference group why it was important and what it felt like to work for the NCAP service user and carer reference group. And we did have mixed responses, but they were generally on the whole overwhelmingly positive. I think Vanessa has touched on this, that we're working within the parameters of an audit and we have limited scope in terms of how we can make a meaningful difference in terms of drawing on our lived experience. And actually, we've had to kind of get creative with kind of translating our lived experience and kind of having an influence. So we've done that in creative ways. We've discussed kind of ethical use of data. We've discussed kind of opt-out procedures. We've discussed kind of how we kind of integrate our lived experience in a meaningful way. And we've brought the data to life. So Ross says, in the meetings, I felt welcomed, listened to and appreciated. This has made a good experience, particularly working with McPin Foundation. So on the whole, it's been a good experience. We felt heard and listened to, whilst having parameters within which we can kind of make a difference. So if we go to the next slide. So as a result of this report, we wanted to co-produce recommendations that could be meaningful to service providers, and we identified 5 key recommendations based on each of our perspectives. So all of the different stakeholders that I've spoken about, as well as our service user and carer reference group. So essentially, we identified the importance of sustaining timely access to all services, including family intervention and CBTP, as well as at-risk mental state and children and young people across England and Wales. We also identified the importance of physical health screening and intervening, and to make sure that is a priority for all service providers, as well as navigating the kind of specifications and parameters of working with NHS England. We also identified the importance of data collection, so using standardised measures of outcome measures that we use to collect data. We also identified the importance of reporting on health inequalities and regional differences, as well as timely access to children and young people support, as well as at-risk mental state, like I've said already. And all of this is underpinned by a need to work in co-produced ways to ensure that the lived experience is integrated into both the audit, but also in terms of how services are run and developed. So one of the key messages is around using co-production. So if we move to the next slide. So how to improve the NCAP service user and reference group. There have obviously been positive and negative experiences of working in the group, and we can always drive that the way the group is run in a better way. We've identified the importance of creating relationships and connections between the NCAP service user and reference group and the wider research team, ensuring that that bridge between the groups are kind of navigated and supported and strengthened, I think, to aid that connection. Another individual says online meetings are convenient and easy, but meeting face to face is really valuable, even once or twice a year. So it's important to have those relationships and form those connections to enable us to work in the audit more effectively. So if we go to the next slide. So just a nod to our former Professor Joe Smith, who was our clinical advisor to the NCAP audit. As the audit is moving towards routinely collected data, we want to keep in mind lived experience. And I think Jo summarizes this really well in terms of her quote that says, we need to keep in mind the people and the interventions that sit behind each code entered. This is not about data, but about people and their treatment experiences and outcomes. So again, it just really reflects the importance of seeing the people behind the data and to ensure that care is taken around how we approach the audit and kind of embed it through the service user and carer lens. So if we go to the next slide. So this is just an end of an era, really. This was taken at a celebratory event for NCAP, where the service user, well, the clinical advisors, Professor Joe Smith and Dr. Paul French, left their posts as clinical advisors after 8 years. And I wanted to just say that I've learned so much from their expertise working with them in implementation groups and steering group meetings. They have been the founding fathers and mothers of early intervention in psychosis services in the UK, and I've learned a lot about audits, I've learned a lot about research methodologies and the service from their expertise. So I'm really grateful to them. And also just to say that I will also be leaving my post after 6.5 years as service user advisor. And I've really enjoyed working with all of the NCAP team, including the service user and reference group, where I've really kind of enjoyed getting to know the group and embedding their voices throughout the NCAP audit. So if we go to the next slide. So like Vanessa said, we were very transparent in our application for this this award. We identified the importance of navigating different perspectives. It was a challenge, as well as the task of reducing all of that data down to 10 pages based on all of our perspectives. And it was a challenge, and co-production is hard. It takes time and effort, and I think it's a credit to how McPin have facilitated the service user and carer reference group in terms of managing different perspectives and weaving in different experiences. So we are really grateful that we can receive this award on behalf of the Patient and Public Involvement Group. And just to say a thank you to HQIP and the awards for this honour. So I'll leave it there. Thank you.
Lovely, thank you. That was brilliant. And there was so much from there that we can take and try to apply to other clinical audits and wider QI projects. There's absolutely loads of learning in there, which is absolutely brilliant. Thank you so much, and congratulations. And obviously congratulations to our other joint winners as well. And we'll be making sure that we share their project as well on the HQIP website. So have we got any questions? Just going to head over to my list of people and see if you can raise your hands if you've got any questions, or for Kim or Meg as well at this point. Again, not seeing any hands. I'm just going to head to the chat as well, just to see if we've got anything that's been popped in there that we can pop to you. Congratulations messages as well. And Jordan, that was on the judging panel, has put a lovely comment in there about how impressed they were with the projects that were submitted. It was a tricky category to judge, so that's lovely. Thanks for sharing that, Jordan. Brilliant. So I think if we're not seeing any hands and we're not seeing any questions, it's a massive thank you to again, and thank you for sharing your presentations, and obviously to Kim and Meg as well. So could we move on? And lovely. So if we move to the next slide, we do actually have an evaluation that we'll just leave this slide up for while I talk to you about the next events, really the sum up, because we've obviously got about 3 minutes to go. So thank you so much for bearing with us with the tech issues today. So please do scan the QR code. Obviously, we want to know if you don't answer anything else in that evaluation, it's your key takeaways really that we're obviously then we'll publish alongside the slide packs and the recordings for you all as well. And obviously we'll use your key takeaways to try and take work forward as we go through the next 12 months. But really just want to signpost you to tomorrow's Lunch and Learn, which is on healthcare inequalities. We've got Danny Keenan, Medical Director from HQIP, joining us tomorrow to give us the key updates there. It's not too late to register for that event. Also, there's a live webinar tomorrow, Better Cardiovascular Care Through Data with CVD Prevent, Dr. Peter Green and Liz Courteville, the King's Fund, and Dr. Vina Raleigh as well. There's lots more resources on the HQIP website if you head over there. Fantastic, thank you. We're getting some links going into the chat now. Case studies, blogs, podcasts, etc. So please do head on over there so that you can access those events. And I think we might have one key takeaway challenge slide that we've just got time to touch on as well, if we could. Lovely, fantastic. So as always, just challenging you really. You've obviously heard from Kim and Meg. We've just heard from the winning categories as well in terms of their shared learning. And I think for us, we'll share the NQICAN slides that obviously we've not managed to cover today, because we looked at the 4 stages of audit and how you can build in that patient and public engagement at all stages of audit. So the challenge here for you is to take away some of this shared learning and think about, for all your audit projects and wider QI projects that are coming through your organisation, whether you're leading on a project as a clinician, whether you work in a clinical audit or effectiveness team or wider QI team, that we are now starting to challenge the methodology and start to work out how can this add more value, how can it add impact, and how can we actually involve the patients and public at all stages of the project to make sure that we're listening and we're shaping health and care in terms of what the patients and public need in our local communities. So we're going to leave you with that challenge. I'd like to thank absolutely everybody that's spoken today. Thank you so much for bearing with us with the technical issues, but at least we identified what it was, so we can ensure that that doesn't happen again as we move through week with all our other events. Enjoy your afternoon, enjoy the rest of Clinical Audit Awareness Week, and we will make the recording and slides available for you on the HQIP web pages, on the NQICAN Future NHS workspace as well. So you have a lovely afternoon, and we look forward to seeing you tomorrow at tomorrow's Lunch and Learn and the other events that are being hosted. So thank you very much.
Mhm.